Hi, my name is Jose Flores, and I am in the medical biochemistry class for the University of New England. And I'm going to talk about the case studies for Unit 4. All right, so we're going to understand a gout case study where we introduce the patient's condition. We have a 47-year-old man presents with severe pain in his right toe. He is unable to bear the weight of his right foot, and there was no apparent trauma. He reports the pain started last night and contributed to an increase in severity. Based on his physical exam and the laboratory findings, he is diagnosed with gout. Gout is a form of inflammatory arthritis caused by the accumulation of uric acid crystals in the joints. It affects normally the big toe, but can also occur in other joints such as the knees, elbows, and wrists. Uric acid is a waste product formed from the breakdown of purines, which are substances found in the body's cells and in certain foods. Normally, the uric acid dissolves and is in the blood and passes through the kidneys into the urine, which is excreted from the body. But gout begins when there is an excess of uric acid in the blood, and it's a condition known as hyperuricemia. This excess can occur due to either an increased production of uric acid or a decreased excretion of uric acid by the kidneys. So he took an exam, and this chart right here shows the exam analysis. We can see that the plasma urate levels from a normal range is less than about 7 milligrams to 100 milliliters. But for the patient's result, he has 10.5 milligrams per 100 milliliters. This means that the patient has hyperuricemia and is indicated by the elevated plasma urate level. This high concentration of uric acid in the blood suggests an increased risk of uric acid crystal formation. When we take a look at the urinary uric acid excretion, the normal range is about 413 plus or minus 78 milligrams every 24 hours. But his result shows 215 milligrams every 24 hours or every day. This means that the patient's urinary uric acid level is significantly lower than the normal range. That means that he's not excreting the proper amount of uric acid from his urine. And it suggests that the kidneys are not efficiently excreting the uric acid and is being held and kept in the blood. The long-term effects and analyzing the case, it shows that repeated gout attacks can lead to chronic gouty arthritis, where the persistent inflammation causes damage to the cartilage and bones of the joint, leading to decreased mobility and pain. Excess uric acid can also crystallize in the kidneys, forming kidney stones, which can cause severe pain and may lead to kidney damage over time. So that's something that our patients should definitely look out for. The overproduction of purines would increase both plasma urate and urinary uric acid, which causes do not match the patient's finding. Decreased salvage purines would similarly increase the plasma urate and potentially urinary uric acid. The decreased urinary excretion is the best explanation because he's not overproducing the amount of uric acid. He's just the output, the excretion is lower than what should be expected. After the patient comes back with more information, after further discussion with the patient, he tells you that he has recently switched from diet soda to regular soda because he read the fake sugar that diet soda had was bad for him. He tells you that he drinks about 4 to 5 liters of soda a day. So the potential impact of this dietary modification, when fructose is consumed, It is rapidly phosphorylated into fructokinase in the liver, converting to fructose 1-phosphate. This process contains ATP, leading to an increase of AMP, and elevated AMP levels accelerate the degradation of purines into uric acid. The biomedical pathway directly links high fructose intake to increased uric acid production. With increased uric acid production, when fructose is metabolized, the liver produces more uric acid, raising the plasma uric levels and exacerbating the hyperuricemia. This increased amount of uric acid levels is probably what happened with the formation of uric acid crystals, and thus leading to gout for this patient. All right, now I'm going to talk about case connection for vitamin deficiencies. We have a patient right here. She's a 58-year-old woman who presents with progressive fatigue, weakness, shortness of breath over the past 6 months. Notable symptoms of hers include mild diarrhea, intermittent numbness, tingling in lower extremities, loss of balance, pale conjunctivas, and a beefy red tongue. The physical examination reveals tachycardia, a systolic murmur, and decreased sensation in the lower extremities. Specific vitamins and analysis that we should look out for include an iron deficiency, which typically presents in the microcytic anemia. The symptoms would include fatigue. Vitamin B6 deficiency associated with microcytic anemia and peripheral neuropathy. Its role in neurotransmitter synthesis, and is a deficiency more common in alcoholics. And a vitamin B12 deficiency. This is the one we're going to focus on a little bit more because it causes a megaloblastic anemia due to the impaired DNA synthesis. And neurological symptoms would include the numbness, tingling, and balance issues, which she is experiencing. Vitamin B12 is essential for DNA synthesis in the formation of a pyrimidine nucleotide called thymidine, and is involved in the conversion of homocysteine and methionine, which is used for DNA methylation. The deficiency leads to the accumulation of homocysteine and methylmalonic acid, or MMA, resulting in impaired DNA synthesis and megaloblastic anemia. B12 deficiency also leads to vitamin B12 deficiency also leads to numbness, tingling, and balance issues as stated prior. Potential laboratory tests would include a complete blood count. This would look for the megaloblastic anemia with high MCV and hypersegmented neutrophils. Serum B12 levels is a test that would directly measure the B12 levels, and low levels confirm deficiency, of course. Serum methylmalonic acid and homocysteine tests would show the elevated levels are specific markers for B12 deficiency. And lastly, we can do a peripheral blood smear, which shows the macrocytes and hypersegmented neutrophils, indicating megaloblastic anemia. So if we have a deficiency, if the patient has a deficiency in vitamin B12, some immediate treatments would include some immediate treatments would include intramuscular injections or a high-dose oral supplement of B12, and assess for the malabsorption issues. Another one would be to monitor B12 levels and CBC regularly to ensure response treatment. And neurological symptoms may take longer to resolve. Early treatment is crucial to prevent permanent damage. Here I've included some references. The American Medical Association, which is a really good one. This was very informative for any B12 deficiencies. And the American College of Rheumatology shows a diagnosis and management of somebody who would have gout. Thank you so much.